Then you are asked, who is your employer?
Yeah.
Who will explain? Who is accountable? Who first of all, you as the provider,
yeah.
Who has engaged you?
Yeah.
Who is your employer? Today, me, when I'm asked who my employer is, I know who my employer is.
Yeah.
But we cannot say about the LOCUMs who has really employed them.
Yeah.
Yeah. So it has to be coming clear so that when you're having these litigations, then the employer also has their part to answer in terms of today. Some of us also did LOCUMs in our early ages.
Exactly.
Yes. And it was very punitive. And that's why today we are glad that we have done some strides and ensured that the terms of employment, they are what they are today. And they are supposed to improve even better.
True.
But what we are saying is, when you are engaged on LOCUM, it means that today you can come to work.
Yeah.
But tomorrow you get another work in the evening today, and tomorrow you say, I'm not coming. But the question is, the patient, does she know whether you are on LOCUM or you are on permanent basis?
No. Good morning, good afternoon, and good evening from wherever you're watching us from. This is the Corridors Podcast. And once again, we're here to give you another episode with another new guest. And so we need to welcome you to the Corridors Podcast. This is where we have conversations abroad and within, domestically and abroad. Now, we're happy that each and every person who's been watching us each and every day has been with us since day one. Na kitu tunataka kusema ni, if you're watching us for the very first time, make sure you're hitting the subscription button. Alafu najua, you press the bell so that you'll be notified each and every time we're having an episode. So, today, there's one thing I've been warned about with the guest that I'm hosting. This man has a lot to share. He's a union leader. He's the chair blood coordinator, Nairobi County. And as well, he's a lab technician. He has a lot of information at disposal. So make sure you're watching this episode to the last minute. So, and to our guest, najua kuna introductions zenye sijafanya, and he's going to introduce himself. Deno, welcome on board, bro.
Thank you so much.
After a very long time. How many years later?
I can't remember, but it's a lot.
Yeah, sure. Yeah. Welcome on board, man.
Yeah, thank you very much. And it's a pleasure being here.
Bless.
So I just, first of all, let me introduce myself for the viewers. My name is Dennis Oduor, Brutus, they call me. I coordinate blood transfusion services at Nairobi City County.
Yeah,
and I'm a passionate blood mobilizer, and I am also a medical laboratory specialist in blood transfusion and a public health advocate. And most importantly, I also chair the county blood transfusion coordinators in Kenya, where we air issues on blood transfusion at our devolved units.
Yeah.
And more specifically now, talking to this forum, to everyone who is listening to me, you are a potential blood donor.
Okay.
And I'm also a blood donor, by the way.
Yeah. Nice.
So I donate regularly. So for us to be able to tell people that donation is good for them, I'm a living example of also what donations are done for me.
Okay.
And the benefits actually outweighs the risks. And just want to share that blood donation is good. And it's not just good for the recipient of the blood, but it's also important for the one who is donating for their health, well-being.
Yeah.
That they just do donations regularly.
Okay.
And just to align to the conversation of today, I just want to say that who are these beneficiaries for this blood, and actually who is a potential blood donor.
Okay.
So I can start with who is a potential blood donor.
True.
So in Kenya, actually, Kenya is a signatory for WHO standards on blood donation. You call it WHA. amended signatory, and we are a country that is very compliant on this. And according to the WHO standards, 1% of the total population of a country should be blood donors. That is when you can easily say that you have a national blood security mechanism. And in that note now, going as per our current population estimates, we need around 560,000 pints of whole blood.
560,000?
Yes, because we're estimated to be around 55 million Kenyans. So if we can have that number of pints, then it means that we can ensure that this blood is always available and it is waiting for the patient, not the patient waiting for the blood.
Okay. Do we usually get these numbers?
Not yet. We are not yet there because actually, as we say, 100% of voluntary non-remunerated donations, we are estimated to be at around 62% of voluntary donations. So we are not yet at the 100% mark.
On voluntary basis.
On voluntary basis.
Yeah.
And we now are over-reliant on family replacement donations, which we know very well it is not what the WHO prescribes for. And also, we've decided as Kenyans that we will only donate blood when an emergency calls
when there's a
for
crisis,
it.
right?
Yeah. And that is not very good because blood is not manufactured. Yes, blood has to be donated, it has to be processed, it has to be safe, and it has to be accessible for any person who might need it anywhere in the Republic. So this means regardless of the county you are from, regardless of which condition informs for this blood, you have to get the right product at the right time for the right patient. Yes, and for this to happen, it means now we have to donate this blood early enough. It has to be processed for. We have to store it in the right temperatures so that it can wait for the next patient calling.
So I hope there's someone out there watching and getting these notes, because clearly there are times you'll be in the hospital and relatives donate blood and they will be insisting, but we have donated blood. Our relative has not been given blood. We have already donated. Possibly the blood was to go under processing, or rather possibly they were to request it from other facility, but to replace with the ones that a relative has donated. What is the what is the process? Maybe you will take us through a process of in case there's an emergency or a crisis. How long does the processing take? Or rather, if it is on voluntary basis, assuming the ones zenye tulikuwa tunafanya in high school, you come, you get a bread. Do they still give bread?
Yeah, we still
bread
give
and
bread
soda.
and soda. Yeah, it is still there. It has never changed.
It has never changed, right? So the ones that we get from possibly the high schools, universities, and centers where there's, donation, the mobilization has been done. Okay. How long does the processing take? And in case there's a crisis, how does it, go by for you to make sure that we had blood to sort the whole crisis?
Okay, thank you very much. First and foremost, I must say that blood can only last for at least 35 days in our fridges. Of course, this blood, when it comes from your body, we have to subject it to some processing where we do component separation. Yeah. And through this component separation, we are able to increase on the blood products that can come from that single blood donation. And we have capacity now to even store for fresh frozen plasma for over a year, cryoprecipitate, used for different treatments of anemia. We also have the red blood cells that we have to store at low temperatures of 2 to 8 degrees. And we also have additives that can be added to this blood, and it can increase its longevity from 35 days to 42 days. Yes. So, and for blood to be donated, first of all, there has to be a recipient expecting to be given this blood, and then we have the donor.
Yeah.
And this donor and this recipient, they don't know each other.
Of course they don't.
They don't know each other. So the first and foremost, it's important to do a lot of public awareness. And that's the first thing we normally do, is to go out there and do some recruitment. And I must say that in our country, and even us when we were growing up, actually personally, the first time I donated blood was when I was in Form 2.
I
And
did the same when I was in Form 3.
Yes, and during that time we used to do it because of a motivation of bread and soda. So you used to see bread and soda, the vehicle is there, and you rush, you want to donate. But unfortunately for me, I did not cut the list of donating because my weight was below the average. You have to be 50 kg
and above.
So I used to make sure that I have to reach 50 kg that I can qualify for the bread and the soda. Back then we didn't know that the blood itself saves lives. We were only doing it because of the bread and soda. But now in the adult life, you come to realize that when a mother is in that maternity and she's delivering and the blood is not there, we lose life.
For sure.
When an accident takes place and a patient is rushed to the nearest hospital with an RTA, there is no immediate blood, we are doing resuscitation, we lose a life.
We lose a life.
We have patients who are born with sickle cell. They need urgent blood transfusion when they are undergoing their sickle cell
Which
crisis.
is one of our conversations today.
We have the cancer patients who are also there when they are undergoing their chemo and they're on treatment. The HB has gone below the requirement and they have to be transfused. And one thing we need to understand is, for blood to be, blood is not just blood. This blood has to be specific to the blood group that the patient is. So as the National Blood Services, we have what we call our blood management information system, where we keep record of every single donor and their blood groups. And even this blood, when we subject it to several test algorithms, it is important for these donors to come back and get their results, and also get the feedback as to if this blood you donated, if it saved a patient. So the most important thing I must say is, we have to urge Kenyans, as long as you are 16 years to 65, to start donating blood. And
as long as their weight is above 50 kg.
Yes, the weight has to be 50 and above. Of course, you have to be physically fit, no any ailment. But also, if you don't know, you can just come to us so that we can check you. So there is that requisite qualification for a donor selection that we have to go through, and it's nationally guided.
And how does it go about with we just from a weekend, right? And someone drank heavily. How does it go about with drinking or other drug use and all that?
Okay, when we have a very comprehensive donor selection criteria, we have a donor selection questionnaire that we ask these questions, and if you fit in that criteria, then that is when you can qualify to donate blood. And I must say, in our country, we have a lot of the young population who are always our target. Because we encourage people, donate blood when you are young. Because you cannot donate blood when you are not yet 16 years and above. Neither can you donate when you are way above 65 years. I know there are countries who do it at 70 years, but we're encouraging you at your youthful year to be a blood donor, and that is the time when you can also understand the benefits of being a blood donor. And just to say this, I know also the young people, we have to enjoy life, and we have a lot of partying. So we also, during our talks, we also talk about living healthy and just ensuring that safety first. And you'll find even when we have a comprehensive donor management system, we are not just looking at the patient receiving your blood, we're also looking at your safety as a blood donor.
Yeah, sure.
And that's why we also ensure that we have to test your blood level.
Okay.
Your blood level has to be 12 and above. If it is below 12, then we cannot donate it. And when we realize your blood level is below, again, we have to give you the right care and we link you for care. Because we also ask ourselves, why are you anemic?
Yeah.
What is the probable cause of
you might anemia? Be one of the reasons why we will need more blood.
So you might be the one needing blood and not the one to be. True. But of course, we also acknowledge the altruism. Yeah, the willingness for you to want to come out and donate blood. As we normally say, it is the lifeline that is more important. And also mentioning that, also I want to urge the young people that at your peak, that is the time you should come in as a blood donor, because there are also a lot of benefits that come out from blood donation. Because right now, you find that most of the young people, we have a very poor culture of even going to the hospital to check our conditions.
Yeah.
I know we are told that if you are supposed to, actually we are registering in SHA, and we are encouraging the young people also to have SHA. But you see also what you are saying is, with SHA, as a beneficiary, maybe you are in high school, then once you are from high school, you are not yet employed, you are out of university. Yeah. Then now you have to have your own medical insurance, not the one for the parent. True. And sometimes some of them you'd find they would not be in this medical cover until maybe they say they get employment, or maybe they're encouraged. But we want to say that as much as your health, we always say that it is your choice. Yeah, living healthy is also as choice. Yeah. And for the young people, we are encouraging that get to take care of yourself. Taking care of yourself is not just having fun. It is also ensuring that you have a culture of wanting to know your bodily status. Yeah. Get screened. Get to know your HB level, check your body weight, eat balanced diet. If you have to drink, don't drink a lot. Just drink, and drink responsibly. Yeah, so you find that, and if you look at the bracket of the beneficiaries of this blood, you'll find that the highest beneficiaries are the young people. Okay. When you're looking at postpartum hemorrhage, where we are saying that blood was not there and a mother lost their life.
And where all the mothers still, in the bracket, the reproductive health bracket.
Yes.
Yeah, of course.
Yeah, that bracket, again, you find it's between the ages of 16 to around 65. True. So those are young people. Yeah, very young. And that is, again, the potential blood donor. Yeah, true. When you look at the number of road accidents, you find most of the victims there, you find they are young people.
The young people, yeah.
You look at the sickle cell conditions. Yeah. You find that most of these sicklers, again, if you don't diagnose them very early at life, then you diagnose them at when they want to start married. True. Most of these at the ages of 26, 30, 35, that is when now you enter into marriage. True. We have a lot of, when the young people get married, that is the time now we realize, we had sickle cell.
There's more diagnoses coming out on, cancer patients with the young, ages.
Yes, and before we used to think that cancer it goes by age. Nowadays we even have cancers that come at very early stages of life, and that's why we're encouraging that. Even as we do the campaigns for blood donation, we're also doing campaigns for cancer awareness, and particularly we are targeting on the young people. And that's why when you're even talking about the young girls, you're talking about the cervical cancer screening, and even nowadays we do immunizations. Yeah. We are looking at also the screening for the breast cancer, which has to be done for them. So we encourage them even in schools. We also have for the men, actually for the cervical cancer, we call it the HPV, human papilloma virus. We also sensitize the young adults. Okay. Yeah, so it's not just for the girls. Yeah. It is also for the younger girls, where they are supposed also to be vaccinated. Yeah. And then also we are also encouraging for the men now, those ones who are going from 40 to 50, we are also encouraging them to do prostate cancer screening. Actually,
Okay.
you know, that is the leading cause of cancer among the male. Yeah, prostate cancer, where we encourage them to do some PSA screening and even DRE.
They don't really like it.
They don't like it. It's uncomfortable. But you see now,
Very uncomfortable.
Yeah, we say at that age, you know, at around 30, there's no risk of you. We don't even encourage you to do
to go
this.
for a DRE, yeah.
But the moment you reach 40, 50 there, now we're encouraging you to do prostate cancer screening.
The DRE is the digital rectal examination.
Yes.
For the obvious, right?
Yeah. And then now we start at 50. And we do it a lot. Actually, I'm glad that we are doing it even. We go to churches and talk to men. You know, men also, they are also a risk group.
Yeah, very tough people.
Risk, those people who don't get to hospitals, when they get sick, then the men would lead the group.
Yeah.
Of course, the young people now, we are also categorizing them around the risk groups, because the young people, they will be there. And you know, when you are young, you don't get sick often.
Yeah.
That's the advantage of being young.
Yeah.
But when you get sick,
cumulatively,
or you find that a sickness is creeping in, and very slowly, and that's why we also have a lot of like things to do with maybe sickle cell anemias. We have the thalassemias. We have the hemophilias.
Yeah.
We have the leukemias. So you see now, like most of the time, you just look healthy, but because you're not used to going to be checked, you never see a disease coming in until maybe it is too late. That is when now it comes to the realization that really you've been sick, and now you have to take action. And most of the preparedness also in terms of when you are healthy, life is good.
It's always good.
It's good. But when sickness comes, you realize even productivity.
Yeah.
And that's why we say, like, even in the terms of the country, when you say that the economy is doing well, it does well when everybody is healthy and they are contributing towards this. When everybody is working and they are generating revenue, collections. Yeah.
Because when you're sick, you're not able to work.
Yeah, when all people who are healthy. Actually, when you look at most of the countries, Kenya and particularly Africa, we are very unique because we have a very rich population for the young.
Yeah.
And these young people now, it's just focusing the priorities to the right direction, ensure that we invest in their health, wellness, and nutrition, of course. We ensure that they eat healthy. Ensure that even in the reproductive line, we have a lot of responsibility. Well, let us plan for pregnancies.
Okay.
Let pregnancies not come in as an emergency, as an accident. Yeah. So that's what we are urging the young people, and also we are saying them, let us be safe. Let us use protection. Let us make sure that even if you are drinking, we don't take it overboard. Yeah. Let us be our brothers and sisters keepers. And you see, when you are doing this, we do these talks during our blood donation sensitization. So it's not just a matter of who ends up donating blood. Of course, at the end of it, it will ask how many pints did we collect?
How many pints
did we collect today? But the most important thing is how many people did we reach out and convince how blood donation is good for them, and how many of those will turn out in the next 3 months to come to donate voluntarily. So, and you asked about the issue about the relatives coming to donate blood. You see, nowadays we say relative donating blood for their patient. So you have a patient who is lying in a hospital. So you are desperate. So that is when you come. And
they get a lot of numbers.
They mobilize the relatives. They mobilize the relatives to come and donate for one of their own. But I tell you, sometimes we see them struggle a lot, because first of all, you need to understand that you should not be doing that. That is the work of the blood donation services, National Blood transfusion services has programs in place to ensure that that is very well done for. But you see, now the problem is the reason why you go and you are told to mobilize donors is because even the hospitals, first of all, I need to make it clear that the hospitals don't keep blood. Yeah, we have the regional blood transfusion centers and the county satellites, which have the mandate and the authority to collect blood from Kenyans. Actually, we don't even allow private hospitals to go out and collect blood.
You don't?
We don't. Because that is a lot of responsibility that has to also have a lot of credibility and transparency. Because you see, you are going to take blood from voluntary, and you're supposed to take it free of charge. You are not supposed to charge them anything.
This brings it back to there are private hospitals who sell blood. Okay, in terms of billing the blood. And I've been in a private hospital where billing would happen to up to 6,000 per pint. But possibly they got this blood from a public facility where, you know, there's coordination. Maybe we have a crisis, we have an emergency, we are looking for a blood, blood group O with rhesus negative. And, you know, it's an emergency. The relatives are made to understand that this is an emergency and it has to be attended to. And in this process, possibly the patient happens to get like 3 or 4 pints. Let's say the patient got 4 pints, and then it has been charged at 6,000 per pint. That sums up to 24,000 when they got the blood for free of charge. What measures are put in place to make sure that this doesn't happen?
Okay, thank you very much for that question. And actually, I get that question a lot of times during our engagements with the public. First of all, the public needs to understand. And I want to quote again WHO recommendations. WHO recommendations advocates for 100% voluntary, non-remunerated blood donors. And to achieve this, it is important that each and every one of us becomes a blood donor. And for that to happen also, we also need to have measures in place to be able to account for each and every Kenyan is a potential recipient for blood, if not donor of the same. So, and it is also important that in terms of preparedness as a country, you at least need to be a blood donor. So in that so doing, we can also know your blood group. By knowing which blood is compatible to you, we at least need to know which blood type are you. So you have to ask everyone, are you my type? Yeah, if you are type A, you can only receive blood from type A and type O. So we also need to know which blood groups do we have as Kenyans. And actually, I've been lobbying for the same way we do census in this country. We could also incorporate blood donation status to be part of the national census. So that way we can be able to know, are you a blood donor in that family of 2 people or of 7 people? Are you a blood donor? It is by so doing that we also know that it is a civic responsibility for us as individual Kenyans to contribute towards availability for blood. And when you're talking about availability of blood, it's also availability for safe blood. You see now this blood, it has to be donated so that it is available. Then coming back now to the aspect of family replacement. Family replacement is a desperate measure by the health providers because they cannot get sufficient blood from the already established blood donation protocols. So they are urging for their patients who need blood transfusion for the relatives to come in and donate. And normally they say that 1:2. So for a patient, they'll need at least 2 donors. So that at least among the 2 donors, one would end up being the exact blood group of the patient, or even in case we are having situation where one blood unit was unsafe, we can still find the other blood unit is safe.
Okay.
But the most important thing is, once we do the family replacement donation as an emergency measure, how do we now ensure that we convert these family replacement donors into voluntary donors?
Okay.
And that's why now, as Dennis, I came up with something called the conversion pipeline.
Okay.
So this conversion pipeline really is just how do we convert the family replacement donors to voluntary and remunerated donors. Because today you are desperate and you came in to donate blood. And even sometimes the way you are told to come donate blood, it is never so nice.
Yeah.
You are desperate, your patient needs it, and you're told if you don't do it, the blood will not be available. Then you already done it.
This is the only thing that
Yeah.
is going to save your patient.
Yes. So now you come up and you donate the blood. Again, you will find out that when you donated maybe 4, only 2 pints ended up being given to your
Safe
patient.
for your
Probably
patient.
those were the only pints that were compatible or the safest
The
that
safest,
were.
yeah.
So you also come, you also agitated. Why only my patient I donated 4 and they only got 2?
Yeah.
But you see, now we are saying we don't need to go through all that.
Yeah, true.
What we are saying is we have to just say that as male, we have to donate blood every 4 times a year. After every 3 months, we turn up, we donate. And once you donate blood, we have already advertised which are the centers that collect blood on behalf of the Kenya National Blood Transfusion. You can only collect blood on behalf of Kenya National Blood Transfusion. That is a mandate that is given by
And you
the
have to
government.
inform the
Yes,
coordinating
it has
team.
to be well coordinated. It has to be very well monitored. It has to adhere to all the safety measures. Yeah, and after this, again, there has to be accountability of the blood. When you talk about somebody saying that my blood, I donated blood, it is important as a Kenyan. Once you've donated your blood, you have to follow up and ensure that this blood, because we also give feedback.
How do you do that?
We have a system called the Damu KE system. It is one of our systems for blood management information system, where every blood collected from a donor, all the details from the donor are put there.
Okay.
Including those who don't end up donating blood. They come in as deferrals, and we have permanent deferrals and even temporary deferral. And even as a deferral, it doesn't mean that today when you come to donate your blood, then you did not qualify to donate blood, that we don't need you. We need you. There's a lot of things that you can still do. You can contribute towards ensuring there is availability of safe blood. First of all is the voice. Yeah, just going out there and talking to somebody about donating blood. The willingness and that altruism. The second thing is you can also help in kind. As you know very well that for the processes, and you had asked me about what is the process of ensuring blood is available.
Yeah.
I've said there cannot be a blood without a blood donor.
Yeah.
And this donor, also the other side, there's a recipient. And they don't know each other.
Yeah.
So the first important thing, there's a team of professionals that always go out there to do a lot of donor advocacy and recruitment.
And sensitization.
Yeah. So this sensitization and recruitment follows immediately. And then after that, we have willing donors coming in to donate their blood. Innocently, without expecting any payment in return. They are just convinced that I think this donation is good for me and I want to do it. And when they do it with the intention that this blood is also going to be given to somebody out there that I don't know their name, but I am going to save a life. And for me now, when I donate this blood, if any of my family members or myself ended up needing the blood, then it will also be available for me. And for that, to ensure that that happens as it is, in our Damu KE system, we have ensured that you are able to be issued by your donor's card. That donor card, which specifies indeed your biodata, who are you, what is your date of birth, what is your blood type, when did you donate, when are you eligible to donate again, and what are the centers you can go to donate your blood. So they are very clearly explained to there.
Okay.
Yeah, so you cannot just go anywhere and donate your blood.
Now,
Okay?
yeah.
Then, once you have donated your blood,
Yes.
you are supposed to, within, actually right now, the turnaround time is within 24 hours.
Within
If
24
goes
hours.
March is 48 hours. Then your feedback is back. And I like the way the government now does its thing,
Okay.
that now we have a e-citizen. Actually, Damu KE is also in e-citizen. So you can just go in there, look at your ID or passport number. Even foreigners can donate blood in Kenya. Yeah, and students, they are not having ID.
But
they
they
can
do
use
it.
their unique identifier,
Yeah.
students' ID. The military, they donate blood a lot. We
A
have
lot
the
of-
Kenya
a lot of
police,
them, yeah.
the NYS. Everyone can donate blood. So once you donate this blood and it is put in that database, then this database, it is also accessible for you, the public, not just us working at the blood services. So you can be able also to access that data and see where your blood went. And you can also get the feedback how your blood went to save other person's life.
Now, assuming I donated some times back,
Yes.
is it possible for me to trace my data?
Yeah, so like, for instance, as we've said that donating blood, you can donate as a man,
Yeah.
after every 3 months.
3
so
months, right?
4 times a
4
year.
times a year.
So, and for this, really, for this to really work, the system is able to tell us, first of all, are you captured in the system as a blood donor?
Have you ever been captured?
Yeah,
Yes.
that is the most important. So kindly make sure you are captured.
Okay.
Yeah, then once you are captured, because I also know that this system did not come in, it has not been there for long.
For a long time,
So there are
yes.
people who used to donate. Somebody tells you, the last time I donated blood was when I was in high school. So you ask them, how many years ago was that? Then
More
they
than
tell
10
you,
years,
More than
20.
10 years. Of course, more than 10 years. We didn't
it's
have
not
such
possible.
a system in
Yeah.
place. But what we are saying is, let us, in a year, during our birthdays, during our Valentine's Day, during our wedding anniversaries, let us identify these special occasions that we can also do periodic blood donations. And we can ensure that when we do this, and I like the way other families do it. I've been invited to family gatherings, wamama ya chama, in December when they are counting the monies and they tell me we also want to donate blood.
Yes.
And we go in and donate blood from them and we issue them with a donor's card and a certificate of appreciation.
Yeah.
Because that actually, right now what we are saying, and we're also looking forward to work with the KRA, because you see, when you are in business, yes,
Yeah.
before you file your returns, I believe all of us file returns,
Yes.
correct?
Yes.
It is important that as a company, as an organization, as a school, as an institution, you also take part in corporate social responsibilities. Yeah, not just about making money and profits. And that's why we are encouraging that every person who is in Kenya, whether you're in business or you are self-employed, we need to ask ourselves, are we also contributing to our well-being as a country? Blood security is a civic responsibility.
That's true.
That starts from you and me. So we need to ensure that we get part in the blood donation activities. And I want to commend the school-going children.
They really do a lot.
Yes, because as a country with over 55 million Kenyans,
Yeah.
it is very unfortunate that we would over-rely on school-going children. And you know very well our school calendars are seasonal.
True.
So we have turned blood donation, our blood availability, to be a seasonal thing. So like right now we are in August. So the schools are closed. So the availability for blood in our blood establishment or even in our hospitals, it has reduced. Because now we don't get a lot of blood donation activities.
That's
like
true.
we normally do, because the schools are closed, the universities are closed. But now we are saying that we don't need to rely on the schools only. We need to rely on every single Kenyan, and that's why today we are saying that we are allowed now to even do corporate blood drives. We can even mobilize donors, and even the hospitals. That's why they are doing the family replacement donations. But again, let me allay something here, because I know it has been asked. Actually, part of the misconceptions we are having around blood has always been on terms of financing for the same.
Yeah.
Because you find somebody says that, we are told to bring donors and then we were charged for the blood.
Okay.
So I want us to understand that blood itself as a product is supposed to be issued for free, because it is also collected from voluntary donors who gave it for free.
Okay.
But we also need to be alive to the fact that this blood processing, the processing of this blood has to undergo through certain financial
Which has its own
implications.
expenses.
Yes, and
Yeah.
that's why we say that now, and I'm glad we are having that conversation.
Yeah.
Because now we have to ask ourselves, what is the costing for blood in this country? For blood to be available, and it's not just blood being available.
I'm
it
happy
is
you're
safe.
asking about the costing, because I'm going to pull you back to, as you answer the question about the costing, I'm going to pull you back to, there's a time it was all in the social media that there are no blood donor, the bags, that, the bags were not available, or those that were available were not fit for the donations. So as you answer that question, maybe you can try and lay anxiety on the same as well.
Okay, thank you very much. And first and foremost, let me rephrase and say that blood as a product, then we have the blood transfusion as a service. So, and we know very well health was devolved. So,
Yeah.
and when health was devolved, it meant that we needed blood available at the devolved units. At that county referral hospital, at that faith-based hospital, at that national referral hospital, we need to have blood there.
Yeah.
So blood transfusion is a devolved function.
Yeah.
And the essence of the Health Act of 207, health is devolved, yeah? And when health is devolved, it means that it is now a responsibility of the government. And we have two levels. We have the county governments and we have the national government. To ensure that there is availability of blood to transfuse and save life.
Okay.
So blood can also be considered as an emergency drug, where when it is not there, then a life can be lost.
True.
So it really depends on how we take it. But the most important thing is, now, for financing for blood, for instance, for that blood to be donated, what are the financial implications? How do we finance for the recruitment, for the mobilization, for the public awareness, for the commodities, for the blood bags, for the screening, which is the most expensive of it all? Because to ensure that only the safest blood, the blood cannot just be screened like any other diagnostic screening. We have a national test algorithm for blood, for donor blood screening. And that's why most of our counties and even facilities are not allowed to screen for themselves blood, because we have to ensure that the standards, the quality assurance aspect of this donor blood is not compromised.
Yeah.
Yes, and you realize then also after that, this blood has to be stored in the right cold chain mechanisms. We have to ensure that the right fridges, the right freezers, and we also need to ensure that there is timely transportation of this blood. First of all, from the collection point to the screening hubs, then from the point of the blood establishment to the hospitals.
Yeah.
And you find that there's a lot of financial implications that come in.
Yeah.
So the question is, how do we finance for these blood services? Because if we get that question right, then, because sometimes we say that the donors are not willing to donate.
Yeah.
But sometimes they are very willing to donate, but they will be failed by the bottlenecks that will be there. Like the way you have said that, do we have enough blood bags? Do we have enough human resource? Do we have enough vehicles? So these are the bottlenecks that we need to address, and those ones can only be addressed during the conversation of financial budget. When we can have budget for blood transfusion services
Is there any?
all our... At the moment at the counties, we have none.
You don't have any budget
We don't have budget for blood transfusion.
So you
services.
solely depend on
We depend
on,
on the national, and
uh-huh.
even at the national level, the budget is not sufficiently to serve all the county blood satellites.
Okay.
And we will only receive what will be availed to us. And we still lobby to the transfusing facilities, which also run from the public to faith-based to private, to support us finance on this so that we can ensure that they have timely availability for blood.
So what is the county doing about this?
So I'm glad that we are having this conversation now at the county levels, because first of all, whether you are a healthcare worker, it doesn't matter whether you are working for the county or you are working for the national.
Yeah.
The most important thing, where you are a healthcare worker and you are faced with a patient who is in dire need of blood transfusion, the priority is to get blood for this patient.
Okay.
And you know very well that blood is always found in our laboratories.
Sure.
So at the laboratory, the doctor will prescribe for the blood in the wards or in theater as an emergency or desperate or an elective case. Then this blood will be requested from the lab.
Okay.
So in most cases, the lab doesn't have blood. So the lab has to escalate this appeal for blood to the county blood satellites or even to the regional blood transfusion centers. And now the question is, if the request gets from the lab to the county satellite, does the county satellites have this readily available blood waiting to be issued to this transfusing facility?
Whenever there's a crisis.
Yes. So in most cases, you find it is not there. So we start the conversation again from the clinical setup. So this patient needs blood. We don't have blood. Can you bring 2 relatives to come donate? So you realize that relative donating blood is not equivalent to that blood being readily available and timely for that patient to be transfused.
And
so you'll realize
that one alone as well will take me to asking you another question. As you continue answering the same, or sorry for cutting you short, there's the auto transfusion. I don't know if you've heard something about that.
Yeah, I will explain on that.
As you go, I mean, you can proceed on this.
I will explain on that. The most important thing, our donation setup in the country is reliant on allogenic donor.
Okay.
Allogenic
what do you
donor,
mean with
allogenic donor is a human being donating blood to another human being.
Okay.
Yes. When you talk auto donation, auto transfusion, now it is self transfusion.
Yes.
So yes, we have provisions where you can also donate for yourself blood. But before I go to that, the donation for blood, as I said before, there has to be a donor and there has to be a recipient. So the most important thing, you have to have a ready donor. The patient is ready, waiting. But what we are saying is, why don't we have a situation whereby the blood can wait for the patient, not the patient waiting for the blood? Because sometimes the patient doesn't have all the time to wait for the blood. And most of this time, that is when you realize that we treat blood as emergency.
We've lost several patients because there
even
wasn't
today, blood. Even today, we are still treating blood as an emergency. Even when we are doing budget at the county level, we talk about blood as an afterthought, which is very wrong. We should ensure that for a doctor, because the doctor is the one prescribing for the blood. The same way we'll say that, do we have enough medicine? Do we have the doctor on duty to take care of the patient? Can we now ask ourselves, do we have the blood? And as we do that also, can we also ensure that the person who handles this blood the person who looks for this blood,
Yeah.
the person who cross-matches this blood, they are also sufficiently employed.
On human resource.
Because, we have a lot of irregular employment in this country.
I'm happy you're pulling me to the question about employment
Yes.
in the counties, okay?
Yes. So let me just finish on that point
please,
before it
just proceed.
evaporates. So you see, like, we want to talk about an issue when it is already a burning issue. But what we are urging that let us have this conversation. Like today, we are in August. We are just about, the counties have just passed the budget.
Yeah.
And health gets the highest share for budget at county level. And I probably believe even at the national level.
Yeah.
But when you ask anyone who sits in those budgetary meetings, allocation meetings, ask them how much money was put in for blood. Probably I tell you will not get a direct answer. But we'll say we have we have money for medicine, we have money for employment of healthcare workers.
Yes.
Yeah, we need specification because today, when you are talking about a patient dying, and I'm glad that we also do audits for the maternal deaths and perinatal deaths that we have. And it is very clear to say that a patient died because there was no available safe blood.
Yeah.
Remember the term, available
safe
blood. So the blood has to be screened. The processes of screening, yes?
To make it safe for use.
The transportation of this blood on time. Not that we are looking for a vehicle to transport blood, then there is no vehicle.
Yeah.
Or if there is a vehicle, there is no fuel.
There's no fuel.
Yes,
Yeah.
so those bottlenecks still come down to the fact that was there blood or not. So you realize that there is no blood, and then now when the patient is in dire need, the healthcare workers are desperate, wanting to save this life. The blood is not arrived yet. Yes, it is 2 a.m. We are looking for blood. Every calls, even these
center.
calls, you have to use airtime.
Yeah.
Yeah, this is when you ask the lab people, they'll tell you, the lab personnel, they'll tell you we don't have a call allowance in our pay slip.
True.
So you want me to make a call. You are asking, the other day we were asking about risk allowance. Yeah. So these are teams that didn't even have risk allowance until we negotiated. And now we are saying even you are risking to, first of all, collect this blood from the public.
Yeah.
Screen this blood. Cross-match this blood. Then you have to issue it to the ward so that our colleagues, the doctors and the nurses can transfuse it. So the question is, why should we discuss the issue about there not being risk allowance or the irrational distribution of risk allowance among the healthcare workers?
Nice.
When this patient is there, they are in dire need of blood transfusion. They have been, even sometimes they even give consent.
Yeah.
You know, blood transfusion has to be consensual. So the patient has consented that
because they are not necessarily communities. I think it's a religion or religions that not necessarily religion.
Okay, actually,
how would I put it?
You see why it's consensual.
Denomination,
you see, consent for the patient is important because remember, first of all, we need to understand what is blood. Blood is a tissue. Yeah?
Yes.
And I always tell the clinicians, when you are prescribing blood, consider yourself prescribing a tissue transplant.
Tissue transplant, yes.
Yes, you are transplanting a patient, a tissue from another person.
Yeah.
So there are risks involved.
Yeah.
Yeah? There is graft versus host rejection.
You
there are
get a
transfusion reactions that can come up of this.
True.
There is even risk of transfusing infected blood, blood-borne infections. Yeah, from the healthcare worker or from the recipient blood.
True.
And because of this risk, I don't think it is okay for us not to finance this area of blood. as much as we finance other areas.
Okay.
Right now, I like the way the conversation is going. For the reproductive health, they've really considered this conversation for blood because they've realized out of every mother who died of PPH, yeah, between 4 to 6 of them die because there was no blood.
Yeah.
And not having blood here in this case means that we also need to ensure that we train our healthcare workers on hemovigilance best practices and guidance for appropriate use for blood and blood products. We also need to increase on our capacity for transfusing blood. Right now, as we are speaking in the country, we have over 15,000 health providers at all levels, clinics, dispensaries, national referrals, county referral hospital, faith-based hospitals. But we only have barely 1,000 of these that have capacity to transfuse blood.
Yeah.
So the question is, why don't we increase blood transfusion? And I like what the National is doing because the National has really, through the Social Health Authority, they have really allowed, and the KMPDC, they are allowing now the level 2s and the level 3s to start exploring transfusion services. And for this to happen seamlessly, it means now we have to employ enough human resource, not just the other cadres, but across all. For example, the blood. Who is collecting the blood? Who is availing it? Who is transfusing it? Who is cross-matching it?
Yeah.
We need to ensure that the numbers. Remember, blood transfusion is dependent on prescription. So when we are employing the clinical officers and the doctors, can we consider the laboratory? Because a prescription comes from the doctor's side saying that I need 2 pints of blood.
With 2 FFPs.
With 2 frozen plasma and maybe cryoprecipitate and platelet concentrate. Yes? Then you find you have 1 medical lab technologist. He is supposed to prepare you that. There's another prescription asking for urine analysis. There's another one asking for stool analysis. So you realize that at the end of the day, it is not fair and you are going to compromise the quality of the services you are receiving. So the one who will suffer is the recipient of the service, which is the patient. And I'm glad that we have bills like the Quality Patient Safety Bill that has undergone processes, even in Parliament. And now we are waiting for the stakeholders' engagement. That has just concluded also. So we can ask ourselves, when we are doing these bills, are we considering the real stakeholders? Because at the end of the day, whatever I'm saying here, that is the reality on the ground. And when you realize now a patient died, and then we ask ourselves, why did the patient die? Was there timely availability of the drugs? Were there sufficient human resource in the hospital to handle this patient? How many patients were being handled
by that time?
Yes, because we need to understand. Right now we are talking about industrial actions. Why are we having several industrial actions? Does it mean during industrial actions patients also go on strike?
Never.
No, they don't go on strike.
They never go on
So we
strike.
need to have these conversations and we need to get it right that indeed we are here to provide services and the person responsible to ensure that the services and the systems are running, they also have to be put on notice that really we need to do our part so that that patient there, because without a patient today, you and I are not employed. It is that patient that makes us be having a job to do.
True.
And you also need to ensure that as we advocate for the patient, we also advocate. I like what one of one of my role models says. He says, without the health worker is the engine that fuels the health system. You can have the nicest buildings, you can have the nicest equipment, but to make sure you have a competent healthcare worker to run, and you also need to ensure that these healthcare workers also, they need to be capacity built.
True.
We need to plan for succession management.
Exactly.
We have a lot of repatriation among our nurses and our medical personnel. And we don't think about replacing. Like today, for me, with over 10 years of training, the knowledge that I've accumulated over the years, just going down the drain, you have not impacted that on the somebody who is coming. Sometimes you ask even some of the counties, when did you employ last? Sometimes even under union, the unions that sometimes push for, kindly just replace for the attritions. Those people who have died, those people who have retired,
those that
those
have
people
gone
who have
outside
become,
the country,
yes, just
those that
replace,
became business.
Because there is no budgetary implication for that.
Yeah.
But you find it's a challenge.
It is a big challenge.
Yeah, and now we want to result into bringing in short-term contracts. You want to employ people and you don't want to remunerate them the same way as the prescribed by the Salaries and Remuneration Commission.
Speaking of which, as you head to that line, the Nairobi County, let me be specific. Nairobi County, City County advertised for LOCUM opportunities.
Yes.
And these LOCUM opportunities, it has faced a lot of backlash through the union, whatever. Now that you're a union leader and you understand what happens throughout this process, they want to employ staffs on short-term contracts, not necessarily even short-term contracts. They call it LOCUM, on LOCUM basis. These staffs being employed are being subjected to same job that any other, let me use a lab technologist, any other lab technologist would have to do out there. They are being exposed to the same risk. Any nurse or any doctor is going to be, faced with the same risk, giving the same, service that a permanent and pensionable nurse or doctor would have been giving. Is it really in position to say that them being employed on locum basis with no risk allowance, with
medical cover,
no medical cover, with the payments at a very low wage, is it really okay for the union to be silent? Some of the unions are silent on this.
So first of all, I want to say that the terms of engagement of employment in this country are very clear. And any employer, be it a private employer or an organization, before you are given that license to employ, or when the Constitution, according to the even the Employment Act, the Constitution of Kenya, the Employment Act, and you have the Labor Relations Act, which clearly stipulates the employee-employer relations. And even if you have employed, we call them now the security guards. We call the house managers. That is a form of employment. And there are clear stipulations on how one should be handled by the employer. You have to have a contract that ensures that your right as an employer, your right as an employee are adhered to. So that is the terms of engagement. So according to the County Public Service Board and the County Government Act of 2012, it also stipulates clearly how employments are supposed to be done. And we have to understand one thing. First and foremost, every year we have budgets. We are supposed to have budgets on employments. So you ask around most of the employers at the county level, even at national level, you ask them, when did you employ last? And how many? How many did you employ? Today, if you ask the HR, the human resource, they will tell you that they are already aware that you are retiring in the next 1 year. And they give you a notice. They will serve you a notice. So the same HR is supposed to plan for your exit and also plan for your replacement. So these things never happen. And I think these are just things I could call them, blanketly, I could call them their systemic failures.
Yeah.
Because when we know this is how things are supposed to be done, then we don't adhere to them like they are supposed to be. Then we create other problems. Like, for instance, the perennial industrial actions that we are having. Do you know the unions? They are not saying something very new. The unions have continuously been talking about issues that they've deliberated with the employers. They have signed return to work formulas with the employers, agreeing even on the time implementations. They have collective bargaining agreements negotiated, signed in court, talking
of
about
years
these
and
issues.
years back in the
So
days.
when you realize now we have to wait until they go out. The healthcare workers now have gone out. That is when now we are busy on meetings, and sometimes we even meet until 1. I remember there's a time we even met until 12 a.m. But still we did not get a resolution.
Okay.
Because of the standings, the grand standings and the threats. You see, first of all, the question I would ask, when did the rain start beating us?
For sure.
Yes. So
Maybe with the evolution?
it is important also the employers to understand that the persons who sit, they also act on behalf of the employer.
Yeah.
Yes. So if you are given a responsibility of ensuring that services are running, just do that. Don't be an impediment to services not being rendered. Today, that Kenyan, that innocent Kenyan, might not know the nitty-gritty.
They don't understand.
Actually, right now, if you ask a Kenyan randomly, why are the nurses on strike? Why are the clinical officers? Why are the lab on strike?
Okay.
They will not know. They'll just tell you, we just know they are on strike, and they are saying the government does not pay them. Yeah, they don't know details. So the question now is, that one is an employer. Yes, that citizen is an employer. Yes, he's the one who voted for people to be elected. So he's asking a question. Me as your employer, can you tell me why I cannot get these services? What is happening to our doctors?
Okay.
What is happening to our nurses? And what is this that you cannot agree with? Right now, as we speak, I don't know, the nurses are on strike for 8 days. I don't know, 9 days.
It is
the clinical officers are actually, I don't know how many days.
Yeah.
But you see, the question is, do we need to have
the medical officers just the other day?
Yes.
I mean,
and why
I think it's a day now.
Yes. So
from,
it means somebody somewhere is being insincere.
Yeah.
If we really had a discussion and we allayed the issues that are having us agitated and have industrial disharmony, and we agree that now we have agreed, can we go back to work and we'll implement? Let us just implement.
Okay.
But when we now become like we are now bringing in, like, there is a lot of insincerity.
Yeah.
There is a lot of mistrust.
Yeah.
The union cannot trust the employer. Now the patient, who will the patient trust? Because the patient doesn't really know what is happening.
Exactly. The patient will be against the medical practitioner.
The patient will think, and by the way, and I've also told, it is also important that the patient also need to understand that why are they seeking services? Because let me tell you, Article 41 clearly stipulates that every Kenyan has a right for highest standard of medical. And also Section 37 also gives the right of an employee through the union to go on an industrial action when they feel like their issues are not being addressed. So you see, everyone, the Constitution guides both sides. But the most important thing I want to urge, as much as, yes, we are urging the unions, and also I'm a union member. I'm also, yes, and I'm also a leader.
Very vibrant.
And I always make sure that before we go to an industrial action, we need to explore all the avenues. And the only challenge now we are having is the insincerity that is from the other side now. Because once we have agreed, it is an agreement. It is signed.
The other side, to mean the government?
Yes.
Okay.
Because you see, you are acting on behalf of the government. You are not the government.
Yeah.
You are replaceable.
Yeah.
But you see, when you are there, if you feel that this is not achievable, don't sign. But when you have signed something that you have agreed, that this one we have agreed and we are going to do it, kindly ensure it is done.
True.
And if you cannot do it, kindly resign from that office. That is the integrity. That is the integrity that there should be there. And we should urge everyone who is acting on behalf of the government. Because let me tell you, you are dealing with human life. Today, there is somebody, I was getting news that somebody had to hang themselves. Because now they are feeling that they were promised permanent and pensionable jobs, and now that it didn't come, they felt that they should. That was a competent healthcare worker who went to a university or a KMTC to train medicine, to train nursing, to train medical lab. And now they felt like they have reached the end of the world. Actually, I can tell you right now, the healthcare workers are the most, actually, I think there are two entities that we should never joke with. We should never joke about our uniformed officers who work in the security, and we should also never joke with our healthcare workers.
Sure.
And the difference is, the people who work in the uniformed forces, they are not allowed to go on strike.
They are never allowed to go on strike.
If
they were allowed to go on strike,
they are not even members of a union. But you see now, for the healthcare workers, first of all, when you're talking about teachers having teacher service commission, parliamentary service commission, civil servants, the union, the healthcare workers, we made sure that when the health was devolved, now it is upon each and every governor in their respective counties to negotiate with their employees. So the question is, when you qualify as a doctor, when you qualify as a nurse, you are not deficient of a nurse when you work in Nairobi County and different from the nurse who works in Mandera or Wajir or Turkana.
As far as
you are professionals, and I believe you can work anywhere, because
and you've been approved by the NCK or rather the board accredits.
Very true. So when we find that a healthcare worker is being paid peanuts to do equal work that their colleagues who have given permanent and pensionable roles. Right now, you see the conversation we are having on the UHC. And actually, we have another group called the Global Fund.
Global Fund.
Yes. And we also have other contracts under health that have been there. They are working. They are contributing to patient quality care. Patients survive due to their, and they show a lot of passion and enthusiasm at work. Then you realize that when it comes to payment, at the end of the month, they don't take away the same. Whether you are qualified, whether you have additional papers, it doesn't matter. There is a lot of irrational employment. And this is now what is making our healthcare worker also be having a lot of problems within themselves. Because we have a lot of mental status issues with our healthcare workers.
And
today,
illnesses.
When you talk about employment and promotions, nobody talks about the workload.
No one ever talked about the work.
But today,
I should acknowledge, only Dr. Liz. Dr. Liz is one of the doctors, one of the hosts from DACO. Apparently, she talks about the burnout and the stresses that comes with the workload and everything else. But that is on a private level. That is her own decision of deciding that this is what I'll be talking about continuously. I've seen her being very vocal about it, and I like that.
So what you are saying is, let us look at quality, not just quantity.
True.
Today, when we stand on one end and say this number of patients were attended, the question is, Did they get quality
Did
services?
they get quality
And
services?
who attended to them?
Exactly.
How long did it take for them to be attended to?
True.
Then you'd realize that really there was, and you see, under lab, we talk about something called quality assurance. Very important.
QA.
Yes, quality assurance. Actually, we are the only cadre that talks about this jealously and defensively.
Yeah.
Because today, if, for example, I went in for a malaria test, what is the turnaround time that I should take for the test to be done and I go back? Remember this sick Kenyan, they had to ask for a sick off from work to go be checked. Yes? They have to account for the time they were in hospital. Then they go and they find the line is so long and they decide, no, let me go back home and come back. This is somebody who should be there building Kenya and bringing revenue to this country. But because now he goes to the laboratory and finds the line is so long and only one officer is attending to all of them, the officer is not allowed to get tired. The officer is supposed to maintain quality of the laboratory results.
The officer is not allowed to break for
He's not allowed to break for lunch, even to go for an emergency call.
Exactly.
They cannot do that. So you'd realize that most of the patients, the clients, they will not get reliable results.
And possibly this officer left home when maybe a relative is sick, but couldn't get a sick off. Or
this is also a breadwinner in that family. Let's say it's a husband.
True.
Today, even you have kids. When your child is sick, and you left your child at home sick, do you think you can go and work? If you know very well, you will be at work, but your mind will
never
be home.
Concentrate at your workplace. Yeah.
And now we realize that most of these contracted colleagues, they are also family members.
True.
Or do you need permission from the government to start a family?
Never.
Yeah. So you have a child in school, you need to pay your housing levy. And actually in Nairobi, nobody stays in their own houses. You pay rent, you commute to work. Then somebody wants to pay you less. Yeah? You are not provided with house. You
no
are
medical cover.
You don't have a medical cover. And you have a family.
No risk allowance.
Actually, no risk allowance. And you see, when all this is happening, somebody is watching. And somebody is even encouraging how we should employ more of LOCUM. Actually, I can tell you, LOCUM employments have no basis, especially when you are dealing with professional healthcare workers. There is nothing like LOCUM. There is no terminology called LOCUM. And the terms of employment are very clear. And this is what we are saying. The only entity that is supposed to discuss salaries of employees in this country is the Salaries and Remuneration Commission. And any employer has to be guided. In fact, before you engage an employee, you need to know what is the market price of hiring. Because today, and I like the way the government does its things, because you have to be very transparent. How many employees do you have? How much on employee salary? How much on employee emoluments? How much on employee CSR activities? How much on employee? You have to account for all that.
Yeah.
And it is high time now we also put the employers on notice that, listen, you cannot bully your employee around and go away with it.
Yeah.
Today, when you have that advertisement and you say these are the qualifications, even the qualification, you need to be guided by what the training needs require.
Yeah, exactly.
Yes, we have professional bodies that govern employment for workers, that license, that train. You need to ask them, what is the role? What is the work do I need? Which work do I need you to do?
Okay.
What are the qualifications? What are the academic qualifications? What are the responsibilities that you are going to do? And then how am I going to pay you? All this has to be part of the contract that you are signing.
Okay.
And then also, how long am I going to work for you? Before now we can review our salary.
Yeah.
Before we can review the terms of engagement.
True.
Yes. Today is only in this country that you'd find somebody who has worked for contract and it is renewed, and they've done it for 6 years. For 6 years, you're
renewing after every 3 months, renewing after every 1
so
month,
in
or
6
after
years,
every 6
in
months.
6 years, you have not even planned for pension for this person.
Not even a single plan on pension.
So this is somebody that will feel like you have wasted their life, and they are young people.
Yeah.
So today you find
all of them are young people.
Today you find somebody is already 40 years. 40 years and you are not employed. Yeah? And the last time you qualified for employment, you have been doing contracts all your life.
Yeah.
You are even a failure in marriage.
Yeah.
You are a failure in even financial preparedness. So who has put you in that compromising situation? So what we want to urge to the employers, let us ensure that we take care of our workers, because our workers, they are the ones who ensure that we at the end of the day, in our work, for it to work, it means the patient has to be satisfied.
True.
The client has to be satisfied. Yeah, and everyone has to be satisfied. And even when you are talking about the feedback, let us have positive feedback from these interventions that we put. So what we are saying is the shoddy contracts that have continued being issued, they are unacceptable. And if they have to be issued, if they are a short term, let them at least be as per the SRC terms.
Now,
so that somebody can be able to take a hold of their life as they prioritize permanent and pensionable employment and job security, but you pay them well to survive and continue working for you. Then you are asked, who is your employer?
Yeah.
Who will explain? Who is accountable? Who first of all, you as the provider, who has engaged you?
Yeah.
Who is your employer? Today, me, when I'm asked who my employer is, I know who my employer is.
Yeah.
But we cannot say about the LOCUMs who has really employed them.
Yeah.
Yeah? So it has to be coming clear so that when you're having these litigations, then the employer also has their part to answer in terms of. Today, some of us also did LOCUMs in our early ages.
Exactly.
Yes. And it was very punitive. And that's why today we are glad that we have done some strides and ensured that the terms of employment, they are what they are today. And they are supposed to improve even better.
True.
But what we are saying is, when you are engaged on LOCUM, it means that today you can come to work.
Yeah.
But tomorrow you get another work in the evening today, and tomorrow you say, I'm not coming. But the question is, the patient, does she know whether you are on LOCUM or you are on permanent basis?
No.
No. Does the patient know that you, today, and we have processes of even ensuring accountability, even for medical negligence or something like that. So these LOCUM, first of all, they are qualified. And I'm glad that we ensure that we insist that they have to be qualified.
Sure.
For us to be sure that they are qualified, then we have to insist that they should be paid equally as their colleagues who are on permanent.
Sure.
Otherwise, we could not be emphasizing on that if we felt. And again, we cannot allow for them to work in our hospitals if they are not qualified. Because that one would bring another problem.
So with the qualification,
with the qualification now automatically, automatically qualifies them to be paid equally.
True.
Because the terms for SRC are clear. And actually these terms are not only applicable for public institutions, they are also applicable for the private institutions. So
private institutions, it's crazy, bro.
Yes, so those privates out there who are not employing, and not paying as per the market price, we are also coming for them. Because we have to insist that we have to respect everyone, Yes, and you have also to understand that this somebody also has other obligations.
Yeah.
First of all, they are taxpayers.
True.
Secondly, they also have families who also depend on them.
Yeah.
Today, for instance, in your house, you have a house help.
Yeah.
This house help, you pay them less than what you should pay them.
Yeah.
Yeah?
Yeah.
Do you think that house help will stay with you?
No.
No. So if that house help, you have a watchman at the gate, maybe in your home, you also have another help.
Yeah.
And nowadays you call them home managers because
managers,
they know you are, when you are busy, most of the time you are at work.
Yeah.
So they take care of your home
Exactly.
as if it is theirs.
Sure.
So the least you can do for them is to pay them well. So this is the same thing now we are urging the professionals. In the hospital setup, we cannot segregate employees on locum and permanent. That is very wrong. Let us pay them right. Even if you are paying them different sources, but let us pay them the right market price payment because they have to survive.
Yeah.
So that they continue working for you.
True.
And I also believe that as an employee, if you don't deliver, then the employer has no reason to continue keeping you.
They will never have a reason.
But if they are satisfied, that's why we also have process of ensuring that when you do, after some period, you are supposed to be eligible for promotion.
Yeah.
And this promotion has to increase
for study
your
leave.
takeaway.
For
You
study
are supposed
leave.
to go back to school to sharpen your knowledge and become even much better.
And
to
create
continue
more opportunity
and
for
create
other people
more
to be
opportunity for
employed.
other people to be employed. So you see, these are frameworks that are available out there.
Yeah.
And it is high time that we explain to our members. And also we want to urge that for you to be, actually want to urge for professional human resource managers to be allowed to take charge of the human resource business. Because even them, they are professionals.
Professional.
Today, as a human resource, when you are qualified, you have to be licensed. For you to be able to go from one position to the next, you need to ensure that you go on certain trainings for you to qualify to handle that.
Yeah.
But there's a lot of irrationality where you find that even the highest paid professional, he's being remunerated by the lowest because we don't care about these things anymore.
Sure.
But in human resource, believe me, there is a provision for that. Personally, as a unionist, I'm also trained in human resource. And that's why I understand these things.
Amazing.
Yes, we understand what is the requirement from the employer side.
Yeah.
That's why when we even go to discussions with the employer, when there's a dispute, we understand the processes. But the only challenge we find is non-commitment. Yeah?
Yeah.
The insincerity
Yeah.
that are found in these boardrooms.
Okay.
When you go there, you discuss, you've agreed, you've signed. And some of these things, even we sign them in front of witnesses who are the legal representations. You know very well the unions also have legal representation.
Of course, yes.
Who advise them on legal issues.
Yeah.
Some of these things you can drag yourselves to court, and the courts, sometimes we even have courts which have predetermined and given directions. Then these directions are defied.
Which affects the healthcare
Yes,
provision.
so you see now, as we are speaking now, the stalemates that we are having, they're just because the system has failed, where somebody is not guided. Somebody has refused to be guided by the rule of law.
You tell them, stay guided.
Somebody has refused to do the right thing. Somebody has decided to become an animal.
Yeah.
Hey, let me say that. Become an animal. Because you are a human being like me. How would you feel if it was your child or your wife or your sibling going through the same?
True.
And also as the healthcare workers also, we also look at patients with a human face. No healthcare workers plans to go on strike, but they're also looking at their families. It's about the money.
True.
It's about the well-being of your family. Today, yes, you are doing the work, but aside from the work, it is also you are humanity. And most of us, we are Christians, or we are Muslims, or we are religious people. Yeah. But what we are saying is, even our religion, I also urge the religious calling to now come and visit our two sides, and we just see how we can broker an agreement. But the most important thing we need to understand that we need to have a human face, and we need to understand that nobody is going to be there forever. And the time you are there to serve, kindly serve with your best of ability, and ensure that no patient, no client does not get the quality service they should get. And in return, also as an employer, ensure that when your staffs do well, you remunerate them well, you reward them well, so that they can continue serving as many, and they can also cascade this good behavior to their colleagues who are coming behind them.
Sure.
So I think that is what we should do.
Thank you.
Yeah.
Thank you so much. That was a good clarification and a good parting shot, because apparently it has been in discussions left, right, and center. But I'm really grateful that you've clarified on how the employment and how the unions play a part, what the government should do, and the county government should do, and all that. And thank you so much for creating time. You've really elaborated it clearly from a unionist level, and from the level of medical laboratories. And getting close to half of the episode discussing on blood donations, transfusions, and everything else. This was a very informative episode for me, I should say, and I appreciate for you making time during your busy schedule. Thank you so much, sir.
I appreciate. Thank you too.
Ambia watu wa subscribe to the YouTube channel, The Corridors.
So thank you very much. I think I've come to the end of this segment. And first of all, it's an honor that you are able to host me today to share my understanding in the health system, and particularly also in the agitation. But now I want to talk to the viewers. First of all, I hope I was able to convince each and every one of you to be blood donors.
Sure.
Yes. Yeah. And to the healthcare workers out there, I'm also one of you. And we just need to do what we were meant to do.
Viva.
And to the employer also, because I am also an employee. So to the employers out there also, I want to urge us that for the systems to work, we are only the upholders of the system. We transact on behalf of the government.
True.
So let us also ensure that the systems are running, so that we are not also part of the impediment that make that things are not running well. Then finally, now I want to urge all the viewers to subscribe to the YouTube channel. And I believe these segments, I am looking forward to be invited in more of them, so that I can share. I have a lot of sharing to give in different angles in the health system, even in just the general public understanding about life. So I believe that called upon again to share, I would be very glad to schedule my time to come. So we want to subscribe to The Corridor, all of us. Amazing. So that now we can share most of these insightful deliberations. Thank you very much.
Thank you. Peace out. That was Dante.